Okay, maybe you're revising male fertility, or perhaps you've just felt, a weird twinge downstairs. Let's be honest, talking about scrotal stuff isn't exactly dinner party conversation.
No, definitely not.
But what if that feeling, that kind of heaviness or noticeable difference, was actually a really key piece in the male fertility puzzle?
Mm-hmm.
Today, we're doing a deep dive into varicoceles. Think varicose veins, basically,
Mhm.
in a much more sensitive spot.
Right. That classic description, bag of worms, often comes up.
Exactly, that squishy, tangled bundle feeling.
And that's our focus today. We want to give you a really clear, high-yield overview of varicoceles, perfect if you're revising.
So the plan is to cover it all. Definition, causes, risks.
Yep, the whole thing. Definition, etiology, risk factors, how it affects things, the pathophysiology differentials, how common it is, what signs to look for, investigations, management, and the prognosis. All based on the essential info from your revision notes.
Excellent. So let's start with that bag of worms. What's the
Uh,
official definition of a varicocele?
okay, so technically, a varicocele is an enlargement and dilation, a widening of the veins within the scrotum, specifically the veins that drain blood away from the testicles.
And that bag of worms description.
It really does
Yeah.
capture that palpable feel, yeah. It's usually on the left side, that's the most common, but it's important to know it can be bilateral on both sides.
And why should we care? Why is it significant?
Well, two main reasons, really. It's a very common cause of male infertility or subfertility. And for some people, it can cause actual scrotal discomfort or pain.
Okay, so these veins get enlarged, tangled. What actually kicks that off? What's the cause, the etiology?
That's the thing. The exact cause isn't fully understood. We don't have one single reason pinned down.
Ah, okay. But theories.
Oh, yes. The main theory revolves around malfunctioning valves inside the testicular veins. These valves are supposed to be one way, making sure blood flows away from the testicle back towards the heart.
Like little gates.
Exactly. And when these gates don't close properly, blood can flow backward. We call it reflux. This increases pressure in the veins downstream, causing them to stretch and dilate. Think of it like faulty plumbing, a dodgy, non-return valve causing backflow.
Makes sense. And you said it tends to show up in younger guys.
Yeah, it's most commonly found in adolescents and young adult men. And as we mentioned, it has this strong preference for the left side.
Why the left side specifically? Is there an anatomical reason?
There is, yeah. It seems to be down to a few anatomical quirks on the left. Firstly, the angle where the left testicular vein joins the left renal vein. The kidney vein is much sharper, almost a right angle compared to the right side. This can make drainage a bit less efficient.
Okay, sort of a tighter turn.
Right. Also, the left testicular vein itself is longer, and it often lacks effective valves right where it connects into that renal vein. And finally, there's this thing called the nutcracker effect, or nutcracker syndrome.
Not correct.
Yeah, where the left renal vein can sometimes get slightly compressed between two major arteries, the aorta and the superior mesenteric artery. This compression increases pressure back down the line into the testicular vein, contributing to that reflux. So the plumbing on the left is just a bit more prone to issues.
Got it. Slightly less efficient drainage on the left. So aside from this anatomical setup, are there things that make someone more likely to get one? What are the risk factors?
Good question. While we don't know the exact trigger, some factors definitely increase the likelihood. Age is one that usually pop up during puberty or early adulthood.
Okay.
Family history is another. If your dad or brother had one, you might be more likely. Suggests a genetic component.
Right.
Then there are things like congenital abnormalities of the veins themselves. Also, anything that increases pressure in the abdomen can play a role. Think chronic coughing, constipation, or maybe even frequent heavy lifting, although the evidence for lifting is a bit debated.
Increased abdominal pressure.
Obesity is sometimes mentioned. Certain pre-existing testicular conditions, like an undescended testicle history, and, as hinted by the family history link, a general genetic predisposition.
Okay. Quite a few things. Any way to remember those?
We could try that mnemonic you mentioned earlier. A fat guy tried constantly. So, age, family history, abdominal pressure, testicular conditions, genetic link, trying, like straining, and congenital vein issues might help stick it in your mind.
Affect like I tried constantly. I like it. Okay, so we know the risks. How does this tangled vein situation actually, mess with things, particularly with fertility? What's the pathophysiology?
Right, so it starts with those faulty valves and the backward blood flow, the reflux, causing the veins to swell up. The big problem, especially for fertility, comes down to temperature.
Temperature.
Yeah, all that extra stagnant blood pooling around the testicle raises the local temperature in the scrotum. Testicles need to be slightly cooler than core body temperature for optimal sperm production, spermatogenesis.
Ah, so it's like constantly having a low-grade fever down there.
Exactly. It overheats the sperm factory, basically. This heat stress impairs sperm production, reduces sperm count, motility, how well they swim, and morphology, their shape.
Okay, so heat is bad for sperm. Anything else?
Yes, the stagnant blood flow can also lead to a buildup of waste products and reduced oxygen supply to the testicular tissue. This causes oxidative stress, which can damage sperm DNA and further impair function.
So it's a double whammy: heat and oxidative stress. Does fixing the varicocele then actually help improve fertility?
That's the key question, and the evidence suggests it can, yes. Especially for men who have demonstrably poor semen parameters, low count, poor motility, etc., or in couples experiencing recurrent miscarriages where a male factor is suspected.
And any specific groups who benefit more?
Well, there's some interesting research looking at testicular biopsy results. It suggests that men whose main issue is hypospermatogenesis, meaning they produce sperm, just fewer of them might see a better improvement in their semen analysis after varicocele repair, compared to men with more severe underlying problems like maturation arrest.
Good to know. So potential for improvement. Now, if someone presents with scrotal swelling or pain, or if a varicocele is suspected, what else could be going on? What are the main differential diagnoses?
Right, you always have to consider other possibilities. Top of the list would be things like epididymitis, that's inflammation of the epididymis, the tube behind the testicle.
Okay, inflammation.
Then you've got hydrocele, a collection of fluid around the testicle.
Yeah.
Or a spermatocele, which is a cyst, usually painless, on the epididymis containing sperm.
Fluid, cysts.
And crucially, although much less common, you absolutely have to rule out a testicular tumor. Any scrotal mass needs careful evaluation for that possibility. So think, inflammation, fluid, cyst, or rarely a tumor.
Got it. Important differentials. So how common are these things actually? What's the epidemiology?
They're surprisingly common. Estimates suggest around 15%, maybe even up to 20% of the general adult male population have a varicocele.
15%. Wow.
Yeah, and it's even more prevalent in adolescents. Interestingly, though, it's quite uncommon in boys under 10. If you see one suddenly appear in an older man, you do need to think about potential underlying causes like kidney tumors obstructing flow, but that's rare.
And the link to infertility.
That's where the numbers really jump out. Varicoceles are found in about 35 to 50% of men presenting with primary infertility, meaning they've never conceived a child.
A third to half.
And get this, it's implicated in up to 81% of men with secondary infertility, those who have fathered a child previously but are now struggling.
81%. That's huge. Really highlights the connection.
It absolutely does. It's considered the most common correctable cause of male infertility.
Okay. So given how common they are, what might someone actually notice? What are the typical clinical features?
Often it's that visible or palpable swelling in the scrotum, usually more noticeable on the left. That classic bag of worms description comes from how it feels on examination, like a bundle of soft, squishy tubes.
The bag of worms again.
Can't escape it. Some men experience symptoms like a dull, aching pain or a dragging sensation, a feeling of heaviness in the scrotum. This often gets worse after standing for long periods, during physical exertion, or towards the end of the day.
Worse with standing or activity.
Exactly. And of course, a major presentation is infertility being investigated for difficulty conceiving and finding abnormal semen parameters alongside a varicocele. But it's also really important to remember that many varicoceles are completely asymptomatic.
So they might just be picked up on a routine checkup.
Precisely. An incidental finding during a physical exam. We also grade them based on size theories. Grade the first is small, only palpable with a Valsalva maneuver, straining. Grade 2 is palpable without straining. And grade 3 is large and easily visible through the scrotal skin.
Grades 1, 2, 3, but just feeling it isn't always enough, especially for infertility workup.
That's right. Clinical examination alone isn't always sufficient, particularly for smaller varicoceles or when assessing the impact on fertility.
Okay, so if a varicocele is suspected or needs proper evaluation, what's the next step? What investigations are typically done?
Well, the physical exam is the starting point. Checking for that bag of worms feel, assessing testicular size, and grading it like we just discussed.
Right.
But the real key investigation, the gold standard for diagnosis, is a scrotal ultrasound. specifically with Doppler studies.
Ultrasound with Doppler. Why the Doppler part?
The Doppler component is crucial because it allows us to visualize blood flow. It can detect that abnormal backward flow, the reflux, in the dilated veins, confirming the diagnosis and helping assess the severity. You need to see the flow to be sure.
So Doppler is key for diagnosis.
Absolutely. Color Doppler ultrasound combines the anatomical image from the ultrasound with the flow information from the Doppler. It clearly shows the enlarged veins and that telltale retrograde flow when the patient strains, confirming it's a varicocele.
Makes sense. What else might be done?
If infertility is the presenting issue, then a semen analysis is essential. We need to look at the sperm count, motility, morphology, the whole picture.
Check the sperm parameters.
Exactly. And in some cases, particularly if fertility is a concern or if testicular size is small, hormone tests might be done. Measuring serum FSH, LH, and sometimes testosterone can give an indication of how much the varicocele might be affecting testicular function.
FSH, LH, hormones.
And as mentioned with differentials, if there's any suspicion of an underlying mass or obstruction, particularly with a right-sided or suddenly appearing varicocele in an older man, first imaging like a CT scan or MRI might be needed to rule out something more serious like a tumor. But for routine varicocele diagnosis, ultrasound with Doppler is the main tool.
Okay, got it. Physical exam, Doppler ultrasound, maybe semen analysis and hormones. So we've covered the what, why, who, how it affects things, differentials, frequency, signs, and diagnosis, big topic management, what can actually be done.
Right, treatment. The main effective treatments usually involve some form of intervention, primarily surgery. The main reasons we treat are persistent, bothersome pain, documented infertility where the varicocele is thought to be a contributing factor, or concerns about testicular growth impairment or atrophy, especially in adolescents.
So surgeries is the main option. What kinds?
There are several surgical approaches. You can go through the groin, that's the inguinal or subinguinal approach. You can go higher up through the abdomen, the retroperitoneal approach, or it can be done laparoscopically, keyhole surgery. Increasingly, microscopic techniques are used for better visualization and ligation, tying off of the problematic veins while preserving arteries and lymphatics.
Ligation tying off the bad veins? Does it usually work?
The success rates for surgical repair, in terms of resolving the varicocele itself, are generally very good. Recurrence rates are typically low, often less than 10%, especially with microscopic techniques.
Less than 10% recurrence. Are there non-surgical options?
Yes. There's also percutaneous embolization. This is done by an interventional radiologist. They insert a catheter, usually via a vein in the groin or neck, thread it up to the testicular vein, and then block the vein using coils or a sclerosing agent.
Blocking it from the inside. How does that compare to surgery?
It avoids an incision, which is an advantage. However, embolization tends to have a slightly higher failure rate or recurrence rate compared to modern surgical techniques. It's a valid alternative, though, especially for some patients.
Okay, surgery or embolization. When should someone actually be referred to a urologist?
Good point. Referral is definitely needed if someone has distressing scrotal pain likely due to the varicocele, or if there are fertility concerns and a varicocele is found. Also, any varicocele detected in an adolescent warrants urological assessment because of the potential impact on testicular growth.
So pain, fertility, or adolescent diagnosis, any urgent referrals?
Yes, an urgent referral is needed if a varicocele appears suddenly, especially if it's on the right side or doesn't reduce when lying down, as this could suggest an underlying blockage. Also, if the diagnosis is uncertain or if there's any suspicion of a testicular tumor alongside it. Otherwise, for a standard varicocele causing symptoms or fertility issues, a routine referral for consideration of treatment ablation, meaning surgery or embolization, is appropriate.
And what about just watching it?
Absolutely. For small, asymptomatic varicoceles, especially in adults not currently concerned about fertility, observation, or conservative management like supportive underwear, pain relief if needed is often perfectly reasonable. Treatment isn't always necessary.
But the surgery for infertility, you mentioned debate.
Yes, that's still an area of active discussion and research. While surgery can improve semen parameters and potentially pregnancy rates for some couples, it doesn't guarantee success for everyone. Guidelines, like those from NIAID in the UK, have sometimes been cautious about recommending surgery solely for infertility, unless semen parameters are significantly affected. It's very much an individual discussion based on the couple's situation, semen analysis results, and other factors. Treatment needs to be tailored.
Tailored treatment. Makes sense. So what's the overall long-term picture? The prognosis?
Generally, the prognosis for a varicocele itself is good. If treated for pain, surgery is usually very effective. For fertility, as we just discussed, the outcomes are more variable.
Depends on the person.
Exactly. While many studies show improvements in semen parameters after repair, translating that into higher natural pregnancy rates is less consistent across all studies. Some research suggests men with clearly abnormal semen parameters benefit most. There was also a mention of low metabolic index, possibly linking to recurrence risk, which is interesting.
And things like IVF.
Right, the role of assisted reproductive techniques like IVF or ICSI, where sperm is injected directly into the egg, is also important here. For some couples, RT might be considered alongside or instead of varicocelar repair, depending on the severity of the male factor and any female factors involved.
What about operating on teenagers early?
Current evidence doesn't really support routine early surgery for adolescents just because they have a varicocele, unless there's evidence of testicular growth slowing down or significant size difference between the testes, or if they have symptoms. It's more about monitoring growth during puberty. So overall prognosis, generally good, symptoms often fixable, fertility impact varies.
Okay. And finally, before we wrap up the details, what are the main complications to be aware of?
The number one complication is infertility or subfertility. That impact on sperm production and function we talked about is the primary concern.
Fertility issues, right? Anything else?
The other main potential complication, though less common and usually only seen in severe, long-standing cases, is testicular atrophy. The affected testicle might actually shrink in size due to the chronic poor blood flow and elevated temperature.
Shrinking of the testicle. Okay, so mainly fertility, rarely atrophy.
Those are the key ones, yes.
Right. This has been incredibly thorough. Let's quickly run through those memory aids again just to help lock it all in for revision.
Good idea. So, for the definition, think bag of worm.
Bag of worms. Got it.
For etiology, causes. Remember the faulty valve and that tricky left-sided angle?
Valve and angle. Yeah.
Risk factors. Use the mnemonic, FAT guy tried constantly.
FAT guy tried constantly. Okay.
Collateral presentation.
Yeah.
Link the bag of worms feel to potential pain and fertility concerns.
Worms, pain,
To
fertility.
investigations. Remember, Doppler is key. Ultrasound with Doppler.
Doppler's key. Check.
Management. Think surgery or embolization is the main active treatment for symptoms or specific fertility cases.
Surgery for symptoms.
And complications. The main ones are fertility issues and, much less often, testicular atrophy.
Fertility and atrophy. Fantastic. That's a really helpful summary.
Hope so.
Now let's try a quick scenario, MSRA style. A young man presents, he's got this dull ache, left scrotum, worse when standing. On exam, you feel that classic bag of worms, most likely diagnosis.
Based on that classic presentation left side, worse with standing, bag of worms feel it's almost certainly a varicocele.
Exactly. Okay, one more. A man, known varicose, trying to conceive, his semen analysis comes back abnormal. What's a primary treatment option likely to be discussed?
In that situation, with infertility and abnormal semen parameters, varicocelectomy, the surgical repair, would be a primary treatment option to discuss.
Perfect. Okay, this has been a really fantastic deep dive into varicoceles. Just to recap the absolute key takeaways.
It's an enlargement of scrotal veins, often feels like a bag of worms, mostly on the left.
It can cause pain, and it's a major correctable cause of male infertility.
Diagnosis hinges on clinical exam and, crucially, scrotal ultrasound with Doppler.
Treatment ranges from just watching it to embolization to surgery, especially for symptoms or certain infertility cases.
And the prognosis is generally good, but the fertility outcomes can definitely vary.
A really solid understanding of this is, well, pretty essential for anyone in medicine, especially if you're facing exams like the MSRA.
Absolutely. And if you are prepping for the MSRA and want more high-yield resources like this, definitely check out pastthemsra.com.
And also freemsra.com for loads of free questions and guides.
Great resources.
So to leave you with something to think about, given that ongoing debate around surgery for varicocele-related infertility, what kind of research do you think we most need? What studies would really help us clarify exactly who benefits most from treatment?
That's a great question to ponder. Definitely needs more investigation.
Something to mull over.
Oh,
Thanks for joining us for this deep dive.